Hi, it's Dr. Centeno, and thanks for joining us today to You've Got the Power. And today I've got an interesting topic because we're going to get into the top 5 stem cell and PRP myths that are out there. I don't spend a ton of time on social media in patient groups, but every once in a while I'll go on the Facebook groups and just get a sense of what people are talking about to see what they understand and what they don't understand, and to kind of get a sense of sort of the myths that are being propagated out there. So I just did that a couple days ago, saw a couple things, and decided to put together this topic. So we're going to talk today about the top 5 stem cell and PRP myths, and we're going to focus on things that I see a lot of that really need to sort of get corrected. Got a little noise in the background there from a siren, so hopefully that doesn't mess with us too much here. Let me go ahead and share my screen, and we will go from there. Okay, looks like that worked, and we'll get the slideshow started here. As usual, you can ask questions at any time. Just put those in the comments. I'm going to start here, spending about 5 or 10 minutes going through a short topic. Then you can ask questions about this topic or really anything else that interests you. Let me just get a pen here and we'll get started. So the top 5 stem cell and PRP myths that I see. So when I go onto Facebook and other social media sites, I see a lot of misinformation being spread on the topic of stem cells and PRP. Now, there is a positive, because I think of providers like myself who do this stuff and know a lot about it, getting out there and trying to educate patients. We're beginning to see that educated patients are many times correcting the record or challenging some of these myths on social media. So that's a huge positive thing to see. We're also seeing educated patients like Dan, who runs the CCI group, who are out there trying to, run a patient experience where information is exchanged. And when things sort of go off the rails, they're trying to keep them on the rails. So I want to give a big shout out to everyone who's out there who has educated themselves, trying to correct the record on some of the crazier things that are out there on social media with regard to stem cells and PRP. So this is a top 5 list of sort of what I see. I just went on social media a couple days ago, just sort of check out what people were saying. And these are sort of the 5 things that I saw. So the first that we'll cover today is that PRP equals PRP, which it generally doesn't. I'll get into what we're talking about there. The second thing, all doctors know how to perform all procedures. Big, big myth. The third thing, birth tissue products sold in the United States contain young and healthy stem cells. The fourth thing, the quality of procedures offered are called the same things are in fact the same. And then finally, a description of where it hurts isn't a diagnosis that can lead to a successful regenerative medicine treatment. So the first is PRP equals PRP. Just some basic education here that PRP comes in 2 types, red and amber, or leukocyte rich and leukocyte poor. The amber stuff for most applications is generally considered better than the red stuff, although there's a few applications where the red stuff may be really helpful. So the type of PRP used depends on what's wrong with you. And then number 2 is that PRP varies wildly in quality by dose. And that goes as low as 1.5x, or just a slight concentration in the platelets that are in your bloodstream, or of the platelets that are in your bloodstream, to 20x, which is a 20 times concentration of the platelets in your bloodstream. So huge differences in dose, and that makes a difference if you're older or middle-aged. It doesn't make as much a difference if you're in your 20s. By the time we get to 35 or so, it starts to make a difference. By the time we get to 45 and 55 and up, it makes a huge difference based on the published literature. Second big myth is all doctors know how to perform all procedures. I see this a lot. Patients don't seem to understand that the expertise of medical providers offering PRP and stem cells varies, again, wildly. So this goes from a doctor who sort of blindly sticks the needle in there, has not a clue where they are, to a doctor that's using fluoroscopy, ultrasound, digital subtraction to place the injection in a specific spot. These are about as far diametrically opposed as you could imagine, but patients generally don't know what it is they're getting. Are they getting this doctor or that doctor or something in between? And it's a huge problem because social media tends to make it worse, right? You've got a patient that jumps on there that's pretending to be an expert that really isn't an expert and sort of steers patients towards someone who's blindly sticking the needle in there. So this is a big problem. And then finally, injecting stem cells IV is not going to treat your low back, your craniocervical instability, or your shoulder arthritis. Another big one that I see that just continues to go and go and go. In fact, I just saw an ad on Facebook by a company called R3, which is perpetuating this myth, and that is that birth tissue products sold in the United States contain young and healthy stem cells. They do not. In fact, we've published the most authoritative paper on umbilical cord products to date with Colorado State University in the world's top orthopedic journal, and it showed that none of the umbilical cord products that we tested that were advertised to have live stem cells had any living and functional stem cells. In fact, these products that are derived from umbilical cord and amniotic tissue or amniotic fluid contain dead and dying stem cells that don't survive. So this is a big, big problem. We still have lots and lots of providers who are perpetuating this scam. So if you see a provider or you see an ad that claims to use, for instance, umbilical cord or amniotic derived tissue that is offering you a quote stem cell therapy, you need to run because that is a scam. Another one is that the quality of procedures offered or called the same things are the same. And we see this one a lot. Here's a great example that I give. You may or may not know that bone marrow concentrate is a same-day stem cell procedure, meaning that bone marrow concentrate contains your own mesenchymal stem cells derived from bone marrow. Now, you can go to two different clinics. Clinic A doesn't spend much time at all doing the bone marrow aspiration. They stick the trocar in there, they draw out what they need, it takes 5 minutes, they're done. That clinic just robbed you as a patient of 90% of the stem cells that were possible to get. Now, Clinic B does the same procedure, meaning it's called the same thing, a bone marrow construct procedure through a bone marrow aspiration, but they take 30 minutes to do the draw. They draw it from multiple sites in small volumes from the bone. And so they get 90% more stem cells than Clinic A. Now, both of those procedures are called the same thing, but they're dramatically different in what they're offering the patient. And the only way to know the difference here is to do your homework at that level so that you understand the difference between those two draws. Now, that's just one thing of many that make up a bone marrow concentrate procedure, but you got to educate yourself at that level. In fact, a mother reached out to me recently through Facebook, asked, should I do this clinic or that clinic? And, I told her what I thought, and she said, thank you so much. It's just amazing how wildly unregulated this area is, because I would not have known the difference unless you told me. And I agreed that is what it is we're dealing with out there. And then finally, a description of where it hurts is not a diagnosis that can lead to a successful regenerative medicine treatment. For example, I have neck pain and headache pain. Will PRP work for me? There are 20 diagnoses that cause neck pain and 20 that cause headache. So without knowing which diagnosis you have, no way I can tell whether or not PRP is going to help you or bone marrow concentrate is going to help you or whatever. Again, a specific diagnosis leads to a specific treatment plan and a specific procedure that will increase the likelihood of success. However, that isn't neck pain, that isn't headache. That's what's causing the neck pain, that's what's causing the headache. So in summary, you got to do your homework in this area. If you don't, you're going to get scammed. And research the quality of what it is you're receiving, both in what's injected and how it's injected. So let me stop sharing here and we'll go to questions here. Looks like we have some. So Finn Bruton, have you an opinion on ozone used to tighten ligaments? Apparently it could be massage toward hard to inject ligaments as a get around. There is much less data published on ozone to treat ligaments. There's a lot more data on prolotherapy. So if you're going to go with one of those, prolotherapy would be the one you'd want to go with. In addition, ozone for clinical treatment is not legal in the US. So several providers using ozonators have had them basically taken by the US FDA because there isn't an FDA approved ozone generator here in the United States. So we've stayed away from ozone for that reason, or those two reasons, and I would suggest that you do too. As far as massaging things in ligaments to try to get them to move to the right spot, that's below the standard of care. You should just place them in the right spot using imaging guidance. And I'm not even sure that massaging would work in most instances. It might work to move the stuff a couple millimeters, but it's not going to work to get it beyond that. It's been advanced by Dane Saman. Since the accessory glenoaxial ligament is deeper, more posterior and lateral, and hugging the spinal canal on the sides, do you routinely inject it? It seems separate, distinct from transverse cruciform, so it's unlikely you get, I believe, injected from there. Yeah, it's interesting, Dan. I know the picture you're talking about from the Tubbs et al. Paper, and I don't think that's where the accessory glenoaxial ligament lives in most people. I think the picture they show is of a posterior placed one. Most of the accessory glenoaxial ligament, based on what we've seen through injection, is in fact farther anterior to that, between the dens and the atlas. So it does routinely get injected. Now, there certainly may be patients where it is far posteriorly placed, like the cadaver they show, but just realize that that's probably not where it lives on most people. Regenics, been advanced by FatGen. Is an asymmetric atlas mentioned by AO Cairo, thicker on one side and the other? Can it relate to instability? It can. It's just not something that anyone's ever looked at in any way as a indicator for instability. We also don't have a lot of data on how many people are walking around out there with zero symptoms who have an asymmetric atlas, meaning a dens in the atlas. So just, listen, from a treatment standpoint, it obviously can be very effective for AO chiropractors to understand what the relationship between those two bones are, C1 and C2. Having said that, we don't have much information about how that relates to instability. Finn, what styloid C1 interval is okay? It'll depend on stability in general. What millimeter of interval do you guys recommend styloid removal? We don't generally recommend styloid removal. So the interval wouldn't be the issue. The issue would be if severe, internal jugular vein compression was found, and everything else short of removal has been tried. That would include something like a PICL procedure if the patient had instability. The problem with removing the styloid, or it's not really the styloid, it's the stylohyaloid ligament, is that it destabilizes the anterior cervical spine. So you wouldn't want to remove it unless you absolutely had to. And even if you had severe compression on one side, that happens in 1 out of 4 normal patients. So we always have to be careful to make sure that everything else that has been tried, short of destabilizing the cervical spine by cutting the ligament, has failed before we go there, and that we've got some data that that's a problem, meaning 2 millimeters might be fine in some patients, meaning there are patients walking around with severe IJV compression who have no symptoms. So we have to be careful. It's been advanced by Carrie Skinner. Could you explain more about how to know which side the alar and accessory atlantoaxial ligaments are lax based on direction C1 is rotating? For example, if C1 tends to be stuck in rotation to the right, also what ligaments are affected if it's C2 is consistently rotated other than C1. The primary ligament stabilizer of C1, C2 is alar, so not the accessory atlantoaxial ligaments for C1 and C2. And which alar would it be? If you look back to that video, you can see that the alar tends to rotate around, and from there, it would be rotation of the head in the same direction, if I'm thinking about it correctly, as the ipsilateral alar. Finn, speaking of quality of procedure regarding a injection provider that had unfortunate misinjection of the brainstem, did they improve their procedures? For example, did they now use contrast? That provider was using contrast. That provider just didn't have experience in doing that extremely rare injection like any of the providers out there outside of Centeno-Schultz Clinic. So again, it's the reason why we talk about that injection being one that you don't go to other clinics to get for that reason. So that's not really a quality of procedure issue. That's just an extremely rare procedure to be performed. So for example, if we take the United States, in the United States, we probably have, I'm guessing at least 5,000 fully trained interventional spine physicians. Of those 5,000, there would be about 100 of those that have done that particular C0, C1 facet injection procedure more than, let's say, 2 or 3 dozen times in their whole career. Of those providers, of that 100, we have 10 that have probably done it more than 100 times, and only one clinic on the face of the earth, Centeno-Schultz, that's done it more than 1,000 times. So that gives you an example of the issue there. Regenetics, been advanced by Amy Norman. Without a DMX, the only upright rotational CBCT and supine MRI, can you determine whether someone would need PRP versus PICL? Upright rotational CBCT and supine MRI. Supine MRI can sometimes be helpful. There are times where, based on that, we can determine whether or not there's a specific issue like a low clavoaxial angle that might indicate a certain type of ligament treatment. A rotational CBCT would be good at looking for that type 2B instability, C1, C2 rotation. So the good news is that's great information to start with. It might need to be supplemented from there. Finn, how soon after prolo PRP can someone get back to curve correction and or anti-inflammatory supplements like fish oil and turmeric? So when it comes to fish oil and turmeric, you can restart really immediately. I don't have a concern about either one of those due to the anti-inflammatory pathways that they work through, which tends to be more the lipo-oxygenase or the LOX pathway rather than the cyclooxygenase or COX anti-inflammatory pathway. As far as curve correction, you can get back to that immediately as well. But there you need to use pain as your guide. So if you were having an awful lot of pain from trying to increase your curve after a procedure, then you got to back off until your pain gets back to sort of normal, and until you can increase your curve without dramatically increasing your pain. Regenix, mid-advanced by Wilson Black. How long after trying posterior PRP treatment for suspected CCI should I wait to do what's needed to be eligible for your PICL procedure? That all depends on the type of craniocervical instability you have and the type of posterior procedure you had done. And so, for example, if you had a type of CCI that should be successfully treated through a posterior injection, and you had a high quality posterior PRP treatment, which would be pretty rare, then you might give it 3 or 4 times, at least 2 or 3, in order to see a result. On the other hand, if you have a type of CCI that we wouldn't expect posterior injections to move the needle at all, then maybe try it once at most. Regenix, mid-advanced by Jerry Skice. A friend of mine had a nurse come to her home to give an IV PRP treatment. Is that safe and is that legal? It is neither safe nor legal. A nurse can't deliver care like that at your home without a physician there to monitor that person. Now, some states have pretty lax physician supervision laws, so that may be passively quasi-legal in some states and absolutely illegal in others. As far as a IV PRP treatment, a friend of mine, I thought this was a pretty funny comment, who's a PhD who understands these things, said that an IV PRP treatment is like pissing in the ocean. And what he meant by that was that you're taking your own platelets, where there's trillions and trillions in your body, and you're taking some amount of those out, you're concentrating those. Maybe if you're lucky and you concentrate them from a large volume of blood, let's say 100 cc's, you might be putting millions back in, but you are putting those in a context of trillions. So it's like pissing in the ocean, meaning it makes no sense at all. That would be a scam for sure. Edwin, 30-minute bone marrow aspiration. Are you saying that if Regenix SC stem cell procedure, will have an anchor trunk on my pelvis for an entire 30 minutes? Can I be anesthetized for that time? Twilight sleep that various Regenix providers offer. Yeah, so Edwin, a properly done bone marrow aspiration takes on the order of 20 to 40 minutes, depending on the skill of the provider, depending on how much is being taken, etc. Now, we offer IV anesthesia for that. Many other Regenix clinics do as well. So, that's something you can definitely get at a clinic that offers that. But that's what it takes to do that right. Now, compare that to, I would say, probably 7 out of 10 providers who are doing bone marrow aspiration procedures are taking the shortcut method. And what is the shortcut method? My glasses are a little crooked here, guys. Sorry. What is the shortcut method? The shortcut method is where they just stick it in there, draw it all out, and then call it good. That takes about 5 minutes. Again, that's really screwing over the patient, because you're getting about 90% fewer stem cells if you do it that way. Not sure what that means, Rhonda. Coincidentally received letter from local ref. Not sure what that means. I think some things got cut off here, Rhonda. Maybe if you could try again. Coincidentally received a letter from local regenerative med doc promoting regenerative biological, and I'm sure there's more to that, but I don't see it. So maybe if you could add that additional detail, that'd be great. It's been advanced by Harry Winston. I've been dealing with my pain and other symptoms with medical marijuana. Can I continue that leading up to it and after the PICL procedure? Yeah, medical marijuana is a two-edged sword from a medical standpoint. On the one hand, it can be effective pain relief, but it's a drug, absolutely a drug, no different than any drug produced by Pfizer. Um, Meaning that most of the drugs that we physicians use are natural substances that are then put into a drug form. No different with THC, the way it's being used today. Um, so the downside risk is that will dramatically increase your anesthesia requirement for the procedure. I'm talking 3x when I say dramatically, which will increase the risk of the anesthesia. And also, there's data showing that it increases pain after the procedure, or that pain control becomes much, much more difficult after the procedure. So on the one hand, it's good because you're not taking OxyContin, meaning it's not as addictive as OxyContin. The bad news is it definitely has impacts. So it will increase the risk of the anesthesia, and it will also increase the risk of having much harder control pain after the procedure, and that's now been pretty well researched. So two-edged sword like anything in life. Diane, what is your recommendation in regards to returning to exercise after seeing PRP in the hip for a labral tear? I would need to know the size of the labral tear. Was it displaced? Was it not displaced? Complete tear, partial tear, stable tear, unstable tear, etc. Raul, hello. I have pulsatile tinnitus. I hear it on both ears. Hear it 24/7. I've seen many doctors who are experts here in New York City. Even regular chiros, cervical chiros, equals nothing. No pain at all. I do have forward head position. Could that be causing it? So one of the more common symptoms of internal jugular vein compression can be tinnitus. Internal jugular vein compression can come from changes in posture. So that's a possible association there. But that's the best I could say with limited information. THM-SVRGS. How common is it with CCI for patients to lose their ability to balance, to do their neck falling out of place? The more time I spend upright, the worse my balance get. Decreased balance or poor balance or disturbances in balance are extremely common in all upper cervical syndromes, including CCI. Submitted advance by DB. Would it be safe to get a stem cell procedure or a PRP procedure while dealing with long COVID? You'd have to define what dealing with long COVID means, but in general, one wouldn't have much to do with the other, but I would need to know more about what you would define as long COVID. Kimmy, can posterior PRP or stem cells help with the reverse curve of the cervical spine? It's certainly going to support the ligament tightness, which is necessary to get there. I don't think it's going to correct it by itself. You would need curve restoration plus that procedure if there was instability. So by tightening those posterior ligaments, we're going to get a better curve. That's the good news. But you're still going to have to push the curve back into place and deal with all the postural issues that can cause the decreased curve in the first place. So not quite that simple, but one does support the other. Okay, here's some more information from Rhonda. Coincidentally, received letter today from local regenerative medicine doctor promoting regenerative biological injection with the umbilical cord derived tissue for help stimulate the healing of arthritis, knee, shoulder, other joints, back and neck pain, promoting as an alternative to prolotherapy. Yeah, that's a scam. I would run, not walk. Listen, first time a sales rep approached me about that was about 7 years ago. They were convinced, actually it was 8 years ago, 2015, they were convinced that they were selling a vial of, quote, stem cells. So I said, listen, we've got $1 million research lab, PhDs that work for us. Let's test it in the lab. If it's got stem cells through some loophole, then I'd be the first person buying this stuff. So we tested it. It had no living stem cells at all. So then I became interested in the topic. I said, this is interesting in that this guy was convinced by the company that this is what was in there. So let's buy some more of this stuff and see what we see. So we bought 3 or 4 more products. We tested them. They were all dead. So then I got really interested. I'm like, this isn't just people making claims they can't prove. This looks like it could be outright fraud. So then we started testing more and more. We eventually published a paper on it. Cornell published a paper on it. UC Irvine published a paper on it. And we all found the same thing, that these products contain no living and functional stem cells. So it's an interesting scam, and there may be some use for these products, but they can't be sold and used that way and be consistent and compliant with FDA guidelines. So it's best just to run away. Kimmy, under what circumstances might posterior stem cells be recommended over posterior PRP? In my book, pretty rarely. Posterior PRP, when we're using it for those types of problems, things like facet injuries, has a high success rate. Now, if it fails, we can then move on to bone marrow concentrate. But usually, because it's less expensive, less invasive, well, we always start, or at least I do, with the least expensive, least invasive thing that's the most likely to work. And if that doesn't work, we go up to the next level. Jingesh, does NUCA and AO help with curve correction too? I live in Houston area and don't have any CBB chiropractor nearby. Generally not. Kimmy, I'm having clogged feeling ears, muffled hearing, depersonalization, derealization, feels like I'm in a dream, floaty. Sometimes you commonly say that associated with CCI. Could be, sure. Finn, patients will vary, but in general, what is the optimal inflammatory sequence for PRP dextrose? For example, very sore neck for 1 day, then 2 days a bit sore, then back to normal. Well, PRP should never be combined with dextrose prolotherapy because that destroys the platelets. So you may want to make sure that we get that part clear first, meaning are we talking about PRP that was combined with dextrose in the same treatment? So give me some info on that. Or were you talking about platelet lysate with dextrose or platelet-rich plasma with dextrose? T.O. Kyles, just want to say I have a herniated disc at L4, bulging disc on L5 in my back, and Dr. Pitts from Broomfield, Colorado performed the PRP procedure back in 2018. Telling everyone that it works and I have no more pain. Thank you, Regenix and Dr. Pitts. Yeah, I'll tell Dr. Pitts for sure. Thank you for letting us know. Fatchen, on my recent CTA, the left IJV is compressed, and there are people walking around like that with no symptoms. But when the IJV is squeezed between the rotated atlas and the styloid, chances of the vagus nerve or other cranial nerves nearby are squeezed too, especially if it has spots like this, for instance. Yes and no. So again, in those people that have severe IJV compression and no symptoms, that's you're assuming that all that same stuff is getting compressed as well. So I think we need to be very careful because one of the things in medicine that's the hardest for patients to understand, and a lot of physicians fall for it as well, is that imaging equals symptoms. It doesn't. Now, that's the reason why we've spent so much time on this channel sorting out things like, how did the person get injured? What are those symptoms? And do those fit things like CCI when we talk about that? Does certain treatments make it better or worse? What does the physical exam look like plus the imaging? And only with all of that can we form a diagnostic picture. But a diagnostic picture in medicine can rarely be formed simply by looking at an image showing a compressed internal jugular vein. So be very, very careful there. Edwin, it's probably known that statins will interfere with regenerative procedures. What about the newer monoclonal antibody medications like Repatha? Well, I don't know if it's widely known, but there does seem to be a likely connection between statins and interference with mesenchymal stem cell related procedures, and that they impact MSCs. As far as the new monoclonal antibody medications, I don't think anyone's published on that to date. Rosalind, if the ligaments are permanently stretched, I'm assuming your body doesn't recognize they're damaged. Otherwise, I'd always try to repair them. So how does PRP help something that isn't damaged? Yeah, Rosalind, PRP, prolotherapy, bone marrow concentrate, all of those work through a mechanism of setting up an acute inflammatory reaction. For prolotherapy, it's local chemical tissue damage. For a PRP or bone marrow injection, it's the body's response to the substance that causes another bite at that healing apple through a inflammatory mechanism. So that's how that works. You've also referred to your research where you found that PRP at about 2x is effective fast at tightening ligaments. Does dextrose have any advantages? Some say PRP benefits don't last. That wasn't really research. That's more just clinical experience doing this stuff for, 25 years, something like that. When it comes to dextrose, maybe even 30. Does dextrose have any advantages over PRP? Not that I can see. One advantage, but it doesn't really relate to this, could be that it causes free nerve endings. It sort of kills off free nerve endings. So there may be an independent improvement in the pain because the local nerve endings are destroyed by the prolotherapy solution. So that's one net positive in the right patient. Ulysses, can C2 cause headaches, especially when it's malrotated? Yes, that is a thing. Rosalind, what would happen if you inject prolotherapy to create injury, then a week later inject PRP? That would be fine. Platelets might be a little confused, but I think it'd be fine. You don't want to put them together because one damages the other, but you can separate them in time. Rahul, thank you in your experience knowledge. How long does spine realignment take? Suggest a cervical or regular chiro. I think a CBP chiro, if that's the goal, would probably be the best. That's chiropractic biophysics, or off the top of my head, I think the web address is www.idealspine.com to find one of those providers. Jingesh, can stem cell produce less inflammatory reactions and pain as compared to PL and PRP? Bone marrow concentrate tends to cause the biggest inflammatory reaction. Then leukocyte-rich PRP, then leukocyte-poor PRP, and then PL. So that's sort of from biggest to lowest. Finn, how many injections in one session do you apply? The nuchal, each capsular, or ligament per facet? It all depends on what it is we're treating, meaning that, again, specific diagnosis of specific structures being injured leads to treatment of those structures. So, for instance, in the nuchal ligament, that can usually be injected at 2 or 3 sites. Capsular ligament, again, is a little bit of a scam because there are very few providers actually injecting capsular ligaments. What their reason why they're claiming they're injecting capsular ligaments is they're putting needles somewhere in the vicinity of the facet joint, but not actually injecting the capsular ligament. So to inject the capsular ligament, you would have to do that under X-ray guidance with contrast. That can be done with a single injection as you're exiting intra-articular. So you've confirmed your intra-articular with fluoroscopy and contrast, and then you're exiting the joint and injecting the capsular ligament on exit with each facet. Rhonda, what application is umbilical cord tissue good for? Just got out today. I got that. promoting for orthopedic joint musculoskeletal problems, alternative prolotherapy and prolozone. Finding here to say is dying tissue. This layer's doc stated it contains growth factors, cytokines, proteins, hyaluronic acid, including mesenchymal cellular stem cells. Yeah, so it doesn't contain any signaling cells or stem cells. Those are all dead or dying. So does it contain growth factors? It does. And so there may be uses there. Those uses are just currently illegal. So best not to get messed up with this. Let me give you a great example. Right now, there are several thousand U.S. medical providers under investigation by the Justice Department because they injected umbilical cord tissue and billed it to Medicare for knees, spines, hips, ankles, etc. Now, each one of these providers is going to owe back tens of thousands to hundreds of thousands to millions of dollars to Medicare with fines. A few are going to go to federal prison. So I wouldn't get mixed up in the middle of this. That's going to be a complete insane show, right? You're going to have your doctor now sending out a letter to you saying, oops, here's a bill for $25,000. We thought that Medicare was going to pay this, but Medicare wants us to pay them back. So you need to pay that money. It's just a mess. So best not to wade into the mess when the whole thing is a scam when it comes to stem cells. Diane Easton Smith. It was a small labral tear with minimal pain with exercising after I gave up impact sports. Yeah, so I think the best thing to say there, Diane, is in general, and again, these are general recommendations for patients who have issues like that. You can get back to walking and light exercising almost immediately as long as it's not causing pain. You wouldn't want to increase your impact sports until you get the thumbs up from the doctor, and that's generally not going to be until about 12 weeks. But that's something to ask the doctor who obviously performed the procedure. Ulysses, they're doctors who the best training we're doing, but not the most training. Not quite sure what that one means. Rosalind, do you inject the posterior atlantoaxial ligament with Prolo resulting in PRP in that area? I think you might mean the lateral atlantoaxial ligament. Yes, we inject the lateral atlantoaxial ligament. I wouldn't use Prolo there because the vertebral artery runs just medial to that ligament. And if you were to inject prolotherapy solution into the vertebral artery, you would kill the patient or come close to it. So definitely not a good idea to use Prolo in that area. So we would only use PRP or bone marrow concentrate for that. It needs to be done under X-ray guidance with digital subtraction angiography at the ready to make sure that you're not in that vertebral artery, because that vertebral artery supplies the blood to the back of your brain. And you can't inject it while you're injecting that lateral atlantoaxial ligament. Ulysses, I'm seeing a lot of naturopath doctors doing CCI procedures with Prolo or PRP or stem cells. Yeah, they're not doing any CCI procedures. It's same thing we've been talking about here, but it brings up a good point. And that point is that there is no naturopath out there that has the training necessary to do the procedures we talk about when it comes to CCI. So that just means to me, I would run, not walk away from that. Again, about the letter from Rhonda, these products are highly FDA regulated. No intention on my part to this guy. Yeah. So the bottom line is they're not highly FDA regulated. In fact, the FDA has sent about 20 warning letters to date to providers and manufacturers of these products. So not at all highly regulated. In fact, that's sort of the problem, because if you're a new umbilical cord tissue manufacturer or reseller, all you really need to do is a quick 45-minute FDA registration, which basically says this is where my business lives. And then they may show up in the next 5 years and inspect your place. But there is no FDA approval. There is no FDA checking on any of that. There is no clinical trial requirement or any of that kind of stuff. So if anything, it's the opposite. It is barely regulated, and that's kind of the problem. Well, know of a place in New York City area where get a DMX, your office, me, 2 places, yet they're 4 to 5 hours away. Yeah, I mean, it's a big problem around the country in that there are not as many DMX places as we would like to see. But having said that, in addition to that, just realize that there are some that we've tried to work with and just don't produce good quality images. So we keep a list of the ones that do good work. So I know it sounds like a far drive, but nothing compared to our colleagues in Europe where there's no DMX at all, or in Canada where we've only found 1 or 2 available. Finn, in my field, cardiac stem cell injections were proved bogus, essentially just like an adjuvant like any other for repair. Is there any evidence to contrary for ligaments? Sure, just send me an email separately, and I'll send you a bunch of different papers. Let's see, I'll put my email address here, Finn. That's the email that goes to my desk. I'm just putting it in the comments there. Ulysses, have you heard of this clinic called Stems 3 Regen? I think you're talking about R3. Yeah, in my opinion, R3 is a scam. They heavily promote umbilical cord, quote, stem cells. They're a reseller of other people's umbilical cord tissue products. There is no evidence that I can find that anything they sell contains any living mesenchymal stem cells. And obviously the peer-reviewed literature that we've published and others have published would also show that that claim in itself is a scam. So that's a good one to bring up. My emails, these email addresses are blocked. How can I fix this? Yeah, I don't know why that is. You can go ahead and just send an email to my personal email address. I'll put that down here. And I'll get that to Carla, and maybe her sending you an email will unblock it. I'm not quite sure why that is, but my personal email just went in the comments there. How come you make the PICL? How come you? I'm not quite sure what that one means. Maybe asking for us to make it cheaper. I'm not sure. Rachel, what is the difference in recovery from posterior PRP injections versus posterior stem cell injections, such as an expected pain source that was after the procedure, time needed to recover prior to returning to work, time it takes for improvements in functioning to start to kick in? In general, posterior PRP injection patients tend to recover quicker than posterior stem cell procedure injections, meaning if we're talking about bone marrow concentrate. So how quickly would you recover? That's a bell curve. So obviously I'm only going to talk about the people in the 95% confidence interval in the middle of the bell curve, but most people would be 3 to 7 days in recovery time. A little bit less for PRP, a little bit more for bone marrow concentrate. And then the soreness after the procedure, again, depends on where you live, but most people would only have moderate soreness after the procedure. And then improvements in functioning for PRP tends to be a little bit quicker in my clinical experience. So 4 to 6 weeks on the bone marrow side, posterior, let's say 6 to 8 weeks in that time frame. Okay, great, everybody. How do you treat the muscle atrophy in suboccipital area, only one side of the neck? The car accident caused damage only on one side. Yeah, so we can do things like inject platelet-poor plasma into the area of atrophy, which may help. but ultimately, it's fixing the problem that caused the atrophy. So that could be a ligament injury, that could be a facet joint injury, and then allowing the patient to strengthen is the only way to fully get over the hump to the other side. Finn, how can injection be deadly under fluoride with contrast? The needle is in the spinal canal. You'd see the contrast spread along it. Right, if the vertebral artery, the contrast washes away. Yeah, the problem, Finn, would be that if you don't know you're in the vertebral artery, so let's take it sort of backwards first. If you do an intraarterial injection, the contrast quickly goes away. Now, what you're hoping to see is the contrast accumulating someplace. But if it's in a joint, sometimes it goes out of your field of view. It goes down the lateral gutter of the joint, so it's difficult to see, which is when you turn on the digital subtraction angiography and see that you're getting an arterial flow pattern. When it comes to placing the needle in the spinal canal into the spinal cord, you would think that that's easy to see, and it would be in most places other than the high upper cervical spine. The high upper cervical spine has an immense amount of overlapping shadows. It's one of the reasons why providers don't like to inject this area, because if you don't look at it all day, you're not going to be sure what it is you're looking at, even if you're very experienced in doing spinal injections. I'll give you an example. People come to our clinic. We do thousands of 01s a year. And, experienced interventional spine guys have been doing it 20, 30 years. We'll look at what we're looking at like deer in the headlights, because they don't look at this area all day. They haven't done hundreds of these to be able to identify exactly where the C0, C1 joint is, where the target is, and with all the overlapping shadows from the skull onto the upper cervical spine, it would be quite easy to get lost and quite easy to not be sure exactly where you are. And so I would expect that has happened more than is a good thing. Finish. Summary note: all injections do not carry risk. Is C0 more risky to inject than C1, C2? So the riskiest would be 01. Next, B1, 2, and then the lower cervicals would be all similar risks, so C2 through T1. Now, again, we've done thousands without incident, so it can all be done competently if you've got a lot of experience at relatively low risk. But in the hands of the average provider that's only done a couple dozen of these, 01 is by far the riskiest. Search up this naturopath called Drew Timmerman, where he's treating CCI patients, and he said, "How better than you? LOL, he's not a real doctor." I'll look him up, Ulysses. I don't know who that is offhand. But again, naturopaths are not physician specialists. And so at the end of the day, they're not going to have the training necessary to do these CCI procedures. And a bigger concern is they're also not going to have the training in sick care. And that's one of the biggest things we've seen with chiropractors and naturopaths that wade into regenerative medicine interventional procedures. For example, here's a great example. I was asked by the person that got injured to look at some medical records of a clinic who performed a knee injection using umbilical cord tissue. This guy got graft versus host disease, it seems like, from the umbilical cord tissue. He also went into renal failure. He had infected knee. And the biggest problem was the person that did the injection was a nurse practitioner who then left the clinic, meaning nurse practitioner comes in, does the injection for the chiropractors that run the clinic, and then the patient is left in the hands of the chiropractors. Now, chiropractors are great at what they do. They're fantastic. But these guys weren't trained how to recognize a knee infection. They weren't trained in how to recognize graft versus host disease. They weren't trained in how to recognize renal failure. And thankfully, the guy's wife was a retired nurse, and she saved his life by taking him to the ER. He gets admitted, put in the ICU, etc. All of that was missed by the chiropractors because they didn't have the training to understand how to work up a possible complication. Why? They were trained in well care. Same thing with naturopaths. They're trained in well care, not sick care. So we MDs take for granted that we grow up in these large university medical centers and we get to see and cut our teeth on, if you will, really sick people. So we get a good sense of what really sick people look like. That doesn't happen in a naturopathic education. That's just not available. So anyway, getting off topic there. I don't see any more questions. Let me know if there's more questions that I can answer. Happy to answer those questions if you have them. Again, today we were talking about the top 5 myths of PRP and stem cells. Talked about all sorts of different things. Different quality of PRP, different quality of injections, fake umbilical cord stem cell injections, etc. Sure, Finn. Happy to help. Drop me a line and I'll get you some of those studies I was talking about. Okay, guys, looks like we are all petered out on questions. I appreciate your time today. I will be here this Friday with another topic. Same bat time, same bat channel. So that's going to be 1 p.m. Mountain Time, 3 p.m. Eastern, noon Pacific. So you guys have a great week. Let me take one more question here. Sorry about that. Tamara, can all Regenexx providers diagnose cervical instability? No. In general, that's not going to be something that is picked up at most Regenexx providers just because it's such a rare diagnosis that they're just not going to see all day. So it's like anything else, right? If a patient walked in my clinic with some rare form of cancer, I'd probably miss it. Simply because I am not trained to identify rare forms of cancer. It's not what I do all day. Yes, I went to medical school. Yes, I went to residency. Obviously, I've seen cancer patients, so I've got enough knowledge about that to know something about it and to know how it interfaces with what I do. But I don't do those sorts of diagnoses every day. I can't look at 5 different moles on your forearm and say that one's probably an issue and needs to be biopsied, but you don't need to worry about these other 4 because I don't do it all day. Same thing with Regenexx providers and diagnosing upper cervical instability. Okay, guys, have a great week, and I will see you here on Friday. Thank you.